Dr. Nitesh Kumar from Bihar, Patna. So now we all know that enucleation is being done with laser fiber, thulium or chromium laser fiber. But today's talk is little bit different. How enucleation is done with monopolar electric current. So let me introduce our speaker today, Dr. Nitesh Kumar. He has done his MCH Urology from Osmania Medical College in the year of 2017 to 19. He is gold medalist in MBBS and MCH and now working as a consultant urologist at Ford Hospital and Sri Kripa Urocare. He is a council member of VR Urological Society and Youth USA. And he has good academic engagements, around 10 publications in different international and national journals. And he is a proponent of supine PCNL and he has published papers also about supine PCNL. His areas of interest are endourology and laparoscopic surgery. And he has a very unique technique of monopolar enucleation of prostate. So we will listen from him. Let us start. Over to you, Nitish.
Yeah.
So first of all, before starting, I will ask you one question. Why did you think differently that you should do with monopolar electric current? Why not do laser enucleation? What is how it is different?
The thing I started doing HOLEPs, but once I got fond of enucleation, then lasers are not present everywhere. So when I had the monopolar current in my hand, I started replicating the same thing what I was doing with the holmium laser. And gradually I developed this technique. And earlier I could only dissect or release the apex and proceed slightly, but now I can also enucleate complete lobe and push it inside. But because other centers are also lacking the this morcellator, so I've developed a modified enuclear resection in which you enucleate majority and then leave the prostate attached to the floor and then resect it. So it helps you in complete removal of the gland. And sentence by eminent urologist, he says enucleation is enucleation is enucleation. Whatever method you use, it's a enucleation thing what you need to do. So
Normal.
yes.
Okay, let us start then.
Okay.
In
So
between, I will stop you, Nitish, if anything required,
yes.
and we will discuss.
Yeah, sure.
Okay.
So I'll go into, yeah. Now screen is visible.
Yeah, yeah, it's visible.
Okay. So as we know, there are few principles of enucleation which we need to follow. And if these are followed, you use any energy, anything, it will go on a very good results and give on very good results, and enucleation will be very good. So the principles are the complete removal of the adenoma. This is the first thing. It produces very less bleeding because when you work between the capsule and the adenoma, you encounter only those vessels which are perforating from the capsule into the adenoma. You'll not encounter the same vessel again and again while dissecting. You will have a early catheter removal. The urethral sphincter is safe because of the early apical release, and you avoid bladder, neck, and urethral complication in your enucleation. So we'll proceed. I
Okay.
will come. I will show this later. The complete enuclear resection thing. So I've named this technique as I bring it all to center. So there's no need for expensive gadgets like laser bipolar modulator and can be done at any center. There's no compulsion for complete enucleation, and it can be learned gradually, and difficult steps for enucleation are made easy. Just a rough cut or animated video to show how the things are done. First, we start at the 12 o'clock or 11 o'clock, and we remove or we just free the adenoma from the capsule beginning from the 12 o'clock until the 6 o'clock. We repeat the same steps on the opposite side, and then we free the apex. This is the apical release of one side. So what we do, we free the adenoma from all around. The similar steps are repeated on the opposite side. We start resecting from 1 o'clock, and then we'll come to the five, at least 5 o'clock, and then we'll retrograde go until here, and whole adenoma or the prostatic gland will be attached just between these areas, the veru and the bladder neck and 5 to 7 o'clock area. And then we resect this bladder neck area. So we free the apex. And
Okay.
after this, we resect this bladder neck area. So everything is in the center, everything lies on the floor, and the resection is very fast, very easy after that. So even 110 grams, or even I have done around 150, even 200-gram glands in 90 minutes can be done. So this step is the last thing, and this will not wobble because continuous length of the prostatic gland is attached from here to here. So wobbling or mushrooming effect, which is developed by the Chinese, what they describe, is slightly different from that. And surprisingly, I came to know about this technique after I started doing it.
Okay.
So, so I'll come to the steps of enucleation. What we do, we first identify the capsule, either with the whole lip or biolip, anything. We either identify the capsule at the 5 o'clock or at the apex or at the 12 o'clock. And then we start to develop a plane between adenoma and the capsule. We preserve the mucosa of the sphincter and then safely release the adenoma from the sphincter. Then we move beyond the plane and reach the bladder neck fibers. We try to prevent subtrigonization and urethral injury and then detach the adenoma into the bladder. So this is the first step, identifying the capsule. So what we do here, we'll first proceed with the cystoscopy. These all videos are slightly 2x for the need of the presentation because it will take too long. So this is the cystoscopy. This was around 70, 65, 70 grams prostate. The sphincter is same nicely. And then we go and see the bladder, ureter, everything as usual. You come back and then at 11 o'clock, we start resecting. This is a modified thing. I will show the complete enucleation part later.
So
So
you give,
from L,
you resect it.
yes,
Okay.
because the capsule is very thin there. So one or two bites of resection will give you the capsule. You can see the glistening fibers. And the
Yeah.
capsule fibers are identifiable now. So this
Yes.
is the one or two bites of resection will give you the capsule. And this is what we need for the enucleation. We need to reach to the capsule. And this
Mhm.
depth will be extended up till the apex. So you can
Okay.
see we are just proceeding distally and we are identifying the capsule. The similar steps are repeated on the opposite side and we can identify the capsule. And once the capsule is identified, we move backwards up to the apex.
Okay.
So this is continuing, coming to the
12
apex.
o'clock.
Yes, 12 o'clock. 12 o'clock you can say either on the either side, 1 o'clock or 11 o'clock. So
Okay.
this is the 1 o'clock resection. So one more thing you can appreciate is the bleeders are pinpoint and you can coagulate them as soon as you find. The field is very clear until now. You'll see later also it's clear. And we try to leave a thin strip of tissues most of the times at a 12 o'clock near the sphincter.
Okay.
So this work has been done. We'll move to
Yeah.
the next step. Okay. So once the capsule is identified, so at bladder neck, we'll start detaching the adenoma from the capsule. This is a coagulation current, and
Yes.
whenever required, this is a cutting current. So when we want to resect sharply, we use the cutting current, and when we want to dissect it bluntly, we use the cutting current. So one more thing you can,
No, I didn't get.
what,
Sorry, Nitesh.
yeah,
You will use cutting correct for resection, no?
yes,
So blunt
no,
force when you will give, and which o'clock
yeah,
you will start it.
yeah, I will show you from beginning. So this is the at 11 o'clock. After
Yeah.
that, the same continuous video. So this is a
Yes.
coagulation current because we are using a blunt force only with the we are using the blunt force only with the piston of the receptoscope,
Loop.
the mechanism, the loop. Not
Hmm.
we are not pushing the receptoscope at any time. We are just
Okay.
using the force of the loop. So when
Okay.
we are at the bladder neck,
Okay.
so these all are coagulation current because we not want to dissect it bluntly. And one more thing, so at this place, I was resecting, but I found that one small twig of the tissue is still attached to the prostatic floor. So you have this
Hmm.
advantage in nuclear resection that whenever you want if difficulty, whenever you feel that some tissue has been left behind, you can directly resect. So there's no need to come again later. You have no need to develop a plane again for it. You can modify or you can just turn around the things whenever you want. So this is at the bladder neck. When we reach the bladder neck, when we want to cut
Just
it,
to push it.
yes, no, that was a cutting current at that
Hmm.
place, at the bladder neck. We'll show you again. So we are just dropping the loops down, and now we are using a cutting current because we are confirmed, and we have almost reached a 5 o'clock there, and we could see the electric orifice. So at this juncture, the whole prostatic gland loops has been fallen down, and everything lies on the floor.
Yes, yes.
So this is a continuation video only. Moving ahead, now we come back at the apex of the prostate. And
Yeah.
as we make an entry in a HOLEP and in AEP enucleation, we'll use a slightly, we can use a coagulation current if the bleeders are more, but mostly we use a cutting current just to incise the mucosa. When the mucosa is incised, the capsule is very thin there, or the gland is very thin. We can easily reach the capsule, and we can appreciate how the gland is lifted. And that
Yes, yes.
incision, which we made earlier from coming from the
Yes,
11 o'clock to the apex of the prostate, that is
yes.
connected with it.
Okay.
So we are connecting, and you can see the apical release being done on the right side.
Yes, yes.
So we will be constantly moving in and out to show the sphincter and mucosa of the sphincter. This cut has been done by the OTs. I usually do OTs
Okay.
for all the cases.
Okay. Do you do up to bladder neck or
Yes,
like
up to
to?
the bladder neck.
Okay, okay,
28 French completely up to the bladder neck.
okay.
And I didn't have had any strictures in the 5 years till now.
Super.
Slightly, when you use a coagulation, this mist will come, the bubbles will come, and you need to go inside the bladder, detach the loop, and come back again. So this will get washed away. There will be few slight oozers or bleeders. You can control them as soon as you find. So this is the apical release of the left side.
Yes.
Now we'll move again, the continuation of the same video. We'll move in between the adenoma and the capsule and we'll develop the plane further. So you can see mostly many a times only by blunt force, it enucleates very nicely. Some prostates are tightly attached with the capsule and some are not. So whenever you find, whenever you are sure you want to cut precisely, because here the sphincter is closed, we'll use a cutting current. And here we are free of the sphincter, so we are using a coagulation current.
So, Nitesh, one question. So,
Yes,
whenever you are pushing, you are using coagulation current,
coagulation
right?
current. Because
And
coagulation,
what
yes,
setting do you keep? Coagulation
same
and
setting, same setting. Setting doesn't change in as TRP 120 and 80.
okay, okay.
So when we do coagulation, the tissues become weak, and this will be easily pushed.
Yes, yes.
So we are almost up to the halfway mark of the gland, and you can appreciate the capsule and the vessels, the horizontal running vessels, which are seen very nicely.
Yeah.
And when any bleeders which we find there can be coagulated then and there. So even if it is a monopolar, there is no bleeding. You can see, you can have a very clear field. Sometimes my whole field vision is slightly insidious, but the monopolar ones are mostly good. And if you encounter a big vessel in a HOLEP or when you are doing a laser, so sometimes it becomes very difficult if they are very big vessels to coagulate them and you need to use a monopolar or bipolar. So
Right.
coming back, I will emphasize one more point here. We were dissecting and we were trying to enucleate, and we find that there's a thin strip of tissue which needs to be cut. So we'll use one or two bites and we'll extend that
Mm.
plane, that capsular plane downwards. So whenever we are near the capsule, we can use our resection technique also. So now you can see that both the planes have merged. So
Correct.
we have a plane at the top, we have the plane at the bladder neck, we have the plane at the apex. In between only we have to merge them. So it becomes very easy. So you have a
Yeah.
guidance everywhere. And in AEP and laser, these guidances sometimes in early phases it's difficult. So this procedure can be taken as a learning or a step up or a step down procedure for the whole lab. You can start this and start learning how to go into the plane, how to develop the plane. Once you get an idea of how the gland looks like and how the planes are, you'll be very confident in doing a whole lab.
Correct.
So the right gland almost has been done and only a few attachments has been left. We'll move to the,
Right.
yes, and this we will move to the right side. Again, we are extending that capsular incision which we made at 11
11 o'clock.
o'clock up till the apex. And here, because the fibers, the capsule gland is thin, you can easily reach up to the capsule. And when we do a regular TURP, these glands or these tissues are usually left out at the apex. We are either afraid of the sphincter or we are afraid that we'll extend beyond. We are afraid of the incontinence. So these things will happen. And these are all mitigated by this modified nuclear resection technique. So this was the right capsular incision up to the apex. And then we'll move to the right apical release. Again, we come at the paravaru area. We incise with a cutting current here with the same setting as we do in a TURP. Any
Yes.
bleeders are coagulated. And then the same thing which we done on the right side, or on the left side, we are doing it here. We are detaching the adenoma at the bladder neck from the capsule. So when we just think about the anatomy of the prostate, all the vessels which come into the prostate, majority are coming either at the capsule, at the or at the apex, or mostly from the flux and flux vessels. So in
5
this
and 7
technique,
o'clock.
yes, 7 o'clock. So we are taking care of all the vessels at the beginning. So at last, when the majority of the resection of the gland is there are no bleeders to feed them, and the resection is almost bloodless, and you can do it very fast. So that's how you can enucleate or enucleoresect a very large gland also. Again, here we find slightly difficulty into getting into the right plane, so we can modify and use our resection to complete that. And once we complete it, the job becomes very easier. We can identify the planes which we have deviated from, and we can proceed again. So this is how it looks like after both the apex has been free. I'll show you in the next video. So one or two nodules were there which were left behind. This can always be resected at the same time. You can appreciate the paravaru area, both the glands, both the lobes are attached there. So it will not wobble, it will not fall into the bladder.
So at this step, you can do either enucleation or resection. No, it doesn't
Yeah,
matter. If you have
Doesn't matter.
morculator, you will go with enucleation.
Yeah, I'll continue the enucleation and then do it. I'll show you one more
Okay.
video. This was with a bipolar. You can appreciate how nicely the glands enucleate.
Eating.
This is the same
Yeah.
same side, right side.
Yeah.
This is a phone recording. I don't know why the recorder's so slightly blackish tinge. Again, you can appreciate very nicely the capsule
Yeah.
and the adenoma. And once you go on rotating, it will just detach. There's not no need of much force. And when you use that coagulation current, it will weaken up. And the fibers which are attached slightly sturdily, it can be done. And you can appreciate those vessels which are running parallel. You'd love to see these vessels when you're enucleating. Again, the mucosal incision is completed. In bigger glands, you can
Mm.
go very far before detaching the apex also. So here there's a slight difficulty in releasing the apex on the right side. So when we are using a nuclear resection, you do not need to struggle here. Just one loop of resection, and then you can see how easy the things will become.
చాలా
Just
అంటే
this,
చాలా బాధగా ఉంది. ఏమైంది? నేను చాలా కిలోమీటర్లు
this just one loop of resection, and now you can appreciate how the lobes are now just sitting there waiting to be enucleated.
Yeah.
The whole scenario changed. The difficult enucleation of the apex became very much easier now. Again, the same thing. It was difficult. The gland was wobbling there. So when we have the plane, we can always resect. So
Yes.
both the lobes has been done now, and this is showing how the gland will look like after 70% enucleation. So, so this is from 5 to 7 o'clock. You can go around and you can see it. And this is the apex. Both the lobes are there, and just you spend 5 more minutes there, and you can push the whole gland into the bladder. And you have easy vision of the bladder. Your 12 o'clock, the difficult area is free. The 5 and 7 o'clock, the ureters, everything is free. The apex is free. And even after this, even if you want to completely enucleate, your work is very much easier. So moving ahead. So now after this, if you want to enucleate completely, you can just enucleate. If you want to resect, you go back again to the bladder neck and come retrograde because
Okay.
you cannot resect it antegrade. And
Yeah.
when you are there, you can see the ureters. There's a no subtrigonization, ureteric injuries, and everything will be mitigated. So again, about the vessels, when you resect the bladder neck, everything will be done. So we are now resecting at the bladder neck, and we'll try to complete the bladder neck all around 360 degrees, and we'll able to appreciate the capsule there. Now you can nicely appreciate it has been merged from the left and right, and there are no bleeding vessels, and the adenoma which was there has been resected.
Correct.
Even
Excellent.
if you have a big median lobe, the resection is
Hmm.
always easier. You can
So one
proceed in the same
question
way.
from viewer is,
Yes.
how do you identify capsule near the apex, paraveri region?
The parallel region just inside the mucosa and start pushing. I'll go back to the slide. Now here you can see you do not need to do anything. You just incise the capsule there, incise the mucosa there. 1 or 2 bits of current, you start pushing. And you can, whatever you see below is a capsule.
Mm.
So the capsule is very thin there. The adenoma is very thin there. You can see, and the best identification of the capsule is the vessels which you see are running parallel to the adenoma or parallel to the capsule. So once you see this kind of vessels, minute,
Mm.
now the next slide I will say.
Okay.
So once you see these kind of vessels, which are running parallel, let me go and say yes. These vessels, can you appreciate?
Yeah,
These
yeah.
vessels are the
Parallel.
indication that you are on the capsule.
With 1 to 2 bytes only you will reach because it is very thin over
Yes,
there.
very thin, very thin. But the laser also or the HOLEP also we do an incision, and as Dr. Gomez says, just push your scope there and you will enter the capsule.
Correct.
So what Gomez Sancha always advocates in size and just push with the scope. And when you push with the scope, you will enter the capsule. And once you identify the capsule at one place, it's just a need to follow it.
Yeah.
So I was at the bladder neck. You can appreciate minimal or no bleeding till here.
Yes, yes.
So the capsule is free all around at the bladder neck. Now, the last part remains resecting the bulk of the gland. This can be done very fast. Everything is lying on the on the floor. You do not need to rotate your scope. And some bleeders might be there, but usually you will not find much bleeder. And you can appreciate this also. It is in 4x, just to, yeah, because this is a slightly lengthy part. And I have compared the resection and the morcellation times. The timings are almost same. In very large glands also, because once we have a beach ball effect, the water, the changing of the scopes, ensuring a perfect hemostasis, these things, the more time to morcellate and time to resect are almost same in my hands.
Same.
So you start from the bladder neck side and start coming retrograde, and you clear apex on one side. Now we have come to the apical area. You can appreciate the mucosa also at these parts. So because the tissue is attached to the midline, it will not wobble. Many were afraid that it can yeah, drop into the bladder and like this. And also sometimes at the apex, because the tissue becomes slightly wobbly, you need to resect few bits like this in a retrograde fashion also. But everything will be clear. There is no need to, there is no fear of digging deep into the tissue. I hope you are able to appreciate it even in
Mm.
4x speed.
Yeah, yeah, yeah.
Yes,
Clear.
because it will take much longer, so I have made it 4x. But now, now you can see one part is almost clear, one side of the gland, and other side, if you want, you can enucleate further and then resect or just resect it and take it out. The whole gland is lies on the floor and ready to be resected. And as I said earlier, you have planes on the, if you're planes on the lateral aspect, planes distally, planes proximally. So all you need is to connect the dots. These are the apical
Known
area.
to unknown.
Yes, known to unknown areas. So, so this is a thing which I wanted to emphasize, that resecting near the paraveru area. So this can slightly become difficult at times because the lobes are wobbly. So sometimes you need to make a reverse cut also, but usually it doesn't affect much. You can see. And you can, yeah, this mucosal strip is left behind. If you want to preserve the ejaculation, you can leave this mucosal strip. So this automatically is a easier way to do a ejaculation preserving TRP also.
Mm.
This strip which
How much
I
tissue do you leave around the?
at least 1.5 centimeter, which I prefer,
Okay.
and proximal to the veru. This is the last 6 o'clock area which you resect at last. And because the patient was old, there was no need to preserve the ejaculation. So we resected it completely. So this is the final look of the fossa, how it looks like. The sphincter is okay. You can see that mucosal pillars which are there
Mm.
when I am coming back. So this mucosal
Mm.
pillars, if you see, na, this is a perfect thing which you can do to the apex. So anything which oozes, which bleeds, you can coagulate. So usually we will have a very nice view of the fossa. You can coagulate or just burn whatever is extra, and any vessels which you encounter can be taken care of. So after this step, even in enucleation, complete enucleation, you can see there's not much bleeder. And for a monopolar to have, or for any morcellation, you need to have a perfect hemostasis. And this can only be given by enucleation technique. So if you look into the bladder also, you'll get a clear vision, and morcellation also can be done easily. So this is the last part. So just see, the irrigation is almost clear. And even on ilex, when we are doing it, you can see the tissues, because the bottle is black, it was almost white. So bleeding is very minimal in this enucleation, in any enucleation, because it's anatomical. You take care of the vessels there, and a complete resection of the tissue is there, so bleeding is minimal. Now, I'll go back to the part which I was trying to show.
Full video.
Yes. So this is a complete enucleation. I'm hoping if you, yeah, anything which you want to ask on the enuclear section thing.
No, this is a nice technique. The to summarize your technique, you
Hmm.
give a incision at the 12 o'clock position from 12
Yes.
to 10 and 12 to 2 o'clock. Then
Yes.
totally you go to the capsule around there. Then
Yes.
you have one known area over there, the roof.
Yes.
Then
Yes.
you come to the paraveru area. Then you
Hmm.
slowly release around the paraveru and just connect from known to unknown, two
Yes.
sides.
No.
Then
Yes.
keep everything attached at the base.
Yes.
Then either you can go with enucleation or resection. It's your wish.
Yes. Yes. It's our wish.
It's a good technique.
Yes.
Anybody
So
can
if
do it anywhere. You can do it.
anybody and anywhere can do it, you do not. You need only a quarter machine that costs around 60,000, or maybe a 1 lakh, a good one.
Right.
So We'll move to the complete enucleation. It's a 6-minute video, so I'll not skip. I'll continue. This is a
Okay.
60-gram prostate. So, and this you can give like a laser. You can use your Collins knife to give a para-veru incision. This was recorded earlier.
Okay.
I do not do it now, so that's why I do not have a first recording. I tried to get a case for recording, but unluckily I didn't get. So this is a para-veru incision, and then you incise at a 12 o'clock area up to the capsule. Then you
No.
connect the 12 o'clock incision from the para-veru area on the both sides.
Okay.
Mucosal incision will connect. So this is the apical release, and the incision part is done. So you can slightly proceed and go into the planes with that this Collins knife. And then as soon as the incision is done, you change it with a monopolar loop. And then you do the same thing. But now we have no resection. Even in a 12 o'clock, we have just incised as we do in a laser. So you can see the stones, which are on more identification part of the capsule. And you can
Yeah.
see these vessels, the parallel vessels. These are also identifying the capsule. So
Yes. Yes.
after that Paraveru area, you go on releasing from the 11 o'clock as we go on dropping in the hollow. And this video, I tried not to resect anything because I wanted to do a complete enucleation. The same thing that the coagulation current weakens, and then when you push, it will detach very easily. This is on the right side from 7 to 11 o'clock. You're going up, and then when you reach the 12 o'clock, you again match those areas from known to unknown.
One question,
Which,
Nitesh, from
yes,
viewer. So while giving this reverse cuts, any risk of injury to rectum?
no, because we are not using a cutting current there. We are only using a coagulation current. A coagulation monopolar current never cuts. If you use a cutting current, then that will be
And
difficult. And when we are
and if you
using a
give any uncontrolled movements, if you are
yes,
always above the capsule, then you won't go below, na?
yes,
Yeah.
and the two things will not run parallel. Either you are burning the tissues or you are pushing it. So you will not push while burning. So whenever you are using a coagulation, never push. Just touch it there, coagulate. It will weaken the tissue and then push with the off pedal. Never push with the pedal on.
So it is like pushing, like normal enucleation also we do with
Yes,
finger
normal.
in open surgery.
Yes,
Just use
it's a open
mechanical
surgery.
blunt force. That's it.
Yes. I always talk with this that dissection is not part. What happened in Iraq, which my perspective is, earlier we used to do a prostate open enucleation, and enucleation was a technique to treat the prostate. Later on, with the advent of this receptoscope and everything, we started using dissection. The idea of giving a traction came from the open surgery because when complete enucleation was done and we could not cauterize all the bleeders, so we used to place it, the Foley's there, and then
Balloon.
compress it, balloon. And the capsule will collapse like this, and then will bring hemostasis. This was again applied to the TURP resection technique. But when we are using the eyepiece, that was a different ball game. But when we have a camera system, I think if you are not having a perfect hemostasis, it's worthless. So traction is not at all beneficial or not at all needed until unless if you leave behind any tissue or if you leave behind any bleeders. For me, as a rule, if any bleeders are there or if the irrigation is red, I will go inside again. I need a perfect clear white or a slight pinkish tinge is okay for me. But if it is more, I will definitely go inside. I never put any traction in any of my TURPs or in nuclear resection or any nucleation, whatever I do. And it has been doing well for last 5 years. There's only one case in which I had to go in midnight and coagulate because of one bleeder opened up and I miss a paraveru bleeder.
Okay. So what I do before
Mm,
morcellation, will
mm-hmm.
stop or almost reduce the inflow by 90%, then
Yes,
look for bleeder. In that
yes,
way, you can be very sure if there is any small bleeder also. If there
yes,
is
yes.
no bleeder at all, then you go ahead
Uh,
with enucleation and morcellation.
yes, yes, yes. And one more different variation of this technique, you empty your bladder, you go
Yeah,
inside, and when you go inside, the apex, the roof will be nearer to you, and
yeah,
with a minimal irrigation. You find out
yeah.
all the bleeders and then coagulate it. If you
Correct.
need to do it twice or thrice, you do it. Even the apical part, the bleeders which cause your interruption or emergency entry into the OT are only two, either at the capsule or at the apex or the paravarial area. So
Paraveru.
these two bleeders will only be missed. And these
Yeah,
paravarial bleeders will not be compressed by any traction. The capsular vessels or the bladder neck around vessels will be compressed, but the
yeah.
paravarial bleeders will not be compressed.
Yes. Will
And they will
continue.
slow. Yes. So you can appreciate here when we are coagulating, when we are using the current, we are not pushing at all. So when we are pushing, we are not using the current at all. So this is a very, some places the capsule attachment is very fine and you can easily just detach it by movement, sweeping movement of the scope. And some places it's tightly adherent. We are reaching the bladder neck area. You can see
Mm.
there's a bladder behind. So you can use a cutting current there also.
Yeah. And it will be a controlled push.
Yes, it
All
will
the
be a
time you will
control
have
push.
vision. Yes.
Yes. So you're not pushing with the scope. And
Yeah.
if even if you push completely the whole loop, it will not go into the rectum mostly.
Yeah.
And the capsule is thicker. So no. So after the part which I showed up till the enucleation of the mid gland,
Mm.
and I said I could either we could move on to enucleation completely, or we could
Mm.
do a resection.
Restricted.
So
Yeah.
after this, we need to change the system. Everyone will have this rolly ball, and
Yeah.
this works very well because the angulation of the prostate will change, and it's not a pinpoint tip, so you can use it for releasing everything. So see how nicely it enters the sexual fluid of the bladder. You have opening the release of the
So this is you are
gland.
using cutting current or coagulation
No,
while releasing.
at the bladder neck we are using a cutting current, but rest of the
Okay.
places for enucleation, for detaching we are using a coagulation current.
Okay.
You can appreciate the difference. Wherever we
Yeah.
use
Yeah.
a cutting current, na, it will rush
Mm.
through. And when we use this, these are all our coagulation. So it
Yeah.
will not rush. And which whenever I have to cut, if I use a cutting current, it will cut. So this way you can finally detach the adenoma and you can always enucleate. And one more advantage, when you have a rolly ball at the last, you can fine tune your coagulation for beginning of the
You use that
morcellation.
for coagulation only. So better
Yes,
coagulation.
so for better coagulation, then you have your next morcellation.
Yeah.
So you can coagulate whatever any bleeders which will disturb you in morcellation, and then you complete the thing with a morcellation. Always look at the apex. Come back, look at the apex. Come back, look at the apex. So you'll have a very
So
nice
one
stream of
question
urine.
from viewer,
Yes.
Nitesh. So have you ever faced bent loops while pushing or like broken loop? Have you ever got
Yes. Loop will not bend. If you are bending the loop, you are pushing too much.
it?
So yes.
Just a
So
gentle
my
push. In
just
the
a gentle
plane, you have
push.
to push gently.
Yes, in the plane you have to push gently. Yeah, if you push very harshly, the yeah, loops will bend. And one more thing which happens, always check your loop when you are doing this technique. Always check your loop once, because this will be the cladding, the yellow cladding of the loop is there, na? That gets eroded. मैंने को बोली ना क्यूआरपी का एक लूप लेके आएगा. तो whenever you do pushing, this yellow cladding will get eroded, and if you're not careful, then it will cause a lateral burn and it can damage your scope also. So even if you are offering this to a patient, it's 800 rupees a loop or 1600 for a expensive loop. It's still cheaper than your modulation. So and lasers. So when I use loop goes on around for 4 cases easily, slightly lesser than what other users will get. But per surgery cost is 200 rupees for me, and I'm happy with that.
Very good. So, few questions, sir. Like,
Yes.
what are the complications you have faced during this procedure? Like
Complications,
compared to whole
some,
lip or tube lip?
yes. Compared to whole lip, sometimes I have encountered capsular perforations because whenever we see a tissue, suppose we are enucleating and we have seen a tissue that is left behind. So we are always eager to resect it more. And during that resection, some capsular perforations will be there, but they do not bleed, and there's not no many, not any need to do anything for that. The next thing, sometimes when you are resecting, a bigger chunk of the tissue can be dropped into bladder, but that can always be pushed back into the prostatic fossa and can be resected.
How, if it is bubbling, how will you resect then? How will you
No, no,
keep it fixed
very,
in?
very small.
Okay.
Suppose means larger than that of your loop, that of your channel size. It will not come through the helix.
Uh-huh.
So yeah, either you can catch hold with the loop and resectoscope, you can pull it out, or you can push place back into the fossa, and then you can cut it,
Resect it.
resect it. I have faced slightly stress urinary incontinence in earlier few of the cases, but they will resolve much faster than what happened with me when I was learning a HOLEP.
Urge
So only
incontinence? Don't know any
large
like any
incontinence
problem?
is a similar thing. Uh, you'll not have that much dysuria, and anything is has not increased. So per se, all the 3 cases which I do, everything is same. And I will tell you the post-op management, post-op sequelae or the post-op uh, journey of my patients. I usually do my surgeries in the afternoon, and the next day morning irrigation is stopped, and next day morning the foliage is out, and they will go back home.
So you keep for 2 days patient.
Yeah, 1.5 days, one and a
Okay.
half to 2 days.
Post of day 2, you remove the folly.
Post-op day 2 morning, we'll remove the foliage, mostly at 36 hours.
And you don't give any traction.
No traction at all.
And how much folly balloon do you inflate? Nothing.
25,
10,
30 cc.
25, 30 Gs.
25, 30 cc, because if at all we need to put a traction, I do not want it to slide it into the prostatic fossa.
Okay. And while this, do you find like suppose we are doing a laser enucleation, we can
दूसरा
see the color
जला
difference
हुआ.
here. If we touch the gland, there will be little brownish discoloration while laser enucleation. If you are in
Yes,
the
yes,
correct
yes.
plane, it will be white.
Yes.
Is there any difference in this monopolar enucleation? If you are
No,
going
no,
through the gland or we through like that,
not much difference. You will identify if you are going through the gland, you will identify. And
same brownish
then
discoloration,
yes,
same
same
brownish.
roundness discoloration. And then and
Yeah,
there you can dissect it. So you can see this is whitish.
yeah,
And if you go into the gland at places, see there a small twig that
yeah.
was left behind, and that will turn into yellow. So if I resect, it will turn into yellow.
Correct.
You can see a slightly cut was there. Few parts they are yellowish and few parts they are whitish. So
Yeah.
this is the distinction which you can get it. The principles are same, and it's
Principles are same.
always
Enucleation
yes, it's always the man behind the machine.
machine.
Yes,
It doesn't
so
matter whether you are doing it with
doesn't matter.
finger or laser or monopolar
Yes,
loop.
yes, and if you have a this thulium, Thulium fibers works like this. I've seen all the thulium guys. They will just push with the scope and burn whatever is in between. So thulium will not have that bubble effect, and it will not enucleate. The laser will not enucleate. Laser will only cut, and you have to enucleate with the scope.
So, no, Dheeraj, have you seen like the Dr. Dheeraj sir will do? He will use more of push and both
Yes,
cutting.
yes, yes,
But Abhay Mahajan sir also will do, Chandramohan sir also will do.
yes.
They do not push so much.
Yeah,
It is a
it's not
combination of
about push.
pushing and
Yes,
cutting. Combination of
yes.
pushing and cutting.
But when you compare the yeah, holmium and this
Holep,
thulium,
holep, holep. That is pure
holep
cutting. Yeah,
holep is pure cutting. You need not to
correct.
push anything.
Even I
Those who are
also
prof
push a little. So
yes,
see, once you go mid gland, you have to just push it and it will give away.
yes, it will
In
give
that
away.
way, it becomes little faster. That's it. But
Yes.
if you
So
should be
once your
always in the
apex,
plane only.
yes, once your apex is released, you can push. But
Yeah,
with the apex attached, pushing is never advised. And now you can
yeah,
see this yellowish part when we are going
yeah,
into the gland.
yeah,
So I'll stop my slides here.
yeah. So few questions from viewers. Like one person again that I asked you already. What are the settings of cutting and coagulation current?
It's the same which you use for a TURP. It's
Yeah.
80 coagulation and 120 cutting.
Yeah. So, have you like anything, any unusual complications so that you had to open or like any, normally we see perforation also. It's
Yeah.
extraperitoneal perforation and fluid collection. Have you ever faced it with the subtrigonalization? Like
No,
nothing, never, never.
subtriagnosis will never happen because you are clearing the bladder neck at first.
Yeah.
So subtrigonization is not with the three-lobe technique. It's not has been heard because you are seeing the bladder, and whenever you see a HOLEP proponents also, they will we are taught in HOLEP that whenever you are if you have a free area here, always come from the released part to the unreleased part. If you want to go from here, the unreleased part, you will directly enter into the trigone.
And what they usually do, they come from the
Mm.
known to unknown. They come
Yes,
from 9 o'clock to base, 9 o'clock to
9 o'clock
base.
to base.
And
Yes,
always keep your laser fiber at 12 o'clock. You little bit
yes,
push more towards the
yeah,
gland. You
little
keep
bit
on
push.
pushing.
So,
And
and
yes,
here we are not doing anything to the bladder neck. We are not trying to enucleate the bladder neck at first. So, when we are resecting the bladder neck in nuclear resection, so there is no chance of subtrigonization. The
yeah,
bladder neck, you are coming retrograde.
yes. Nice presentation, Nitesh. And we had this everything. The message should go to all, whether wherever you are, you can do it. In fact, when I started thulium enucleation, first
Yes,
23, 30 cases I did this way only. Then
yes,
slowly, when I got the confidence of lifting the gland, switched over to flip. But
yes.
again, then also from 10 cases, again you have to stop in between and take help of like that. In that
Yes, you
way, we
take
can start and
and
continue.
yes, you can start and continue. And whenever you, so I also did the same thing. I started my holmium till the point I was comfortable. I'll go with the holmium. And few cases, one in a blue moon, one out of five cases, it will go very nicely. Again, four cases, I will struggle and I have to switch over to the loop. And in those scenarios also, I started experimenting with these things. And when you switch over to the loop, now the things become slightly difficult because we have detached the paravary area and that gland wobbles when you resect it. So
Yeah.
one more, yeah, this many people think that HOLIP is not necessary, nucleation is not necessary. Why to invest into such hefty gadgets? Even if I invest, whether will I be able to do it or not? So I wanted to do this presentation only because this is a very good step down or learning step for those who want to do a enucleation or start learning the enucleation. You do whatever up till whenever you are comfortable. The moment you feel, no, I am not able to do it, just resect. So no need to change the instrument, no need to spend on expensive gadgets. So once you start enucleating, even up to the middle and whenever you get hands on the laser, you will always be able to do it.
Correct. So the message is you can try always. And the problem with TURP is once you at the end of the surgery, if you empty the bladder, once you
Hmm.
go again, there will be some tissues will be there. There are
Yeah,
lateral lobes. Then
some tissues
these
will
will
be there.
come, and these are like
Yes,
demons. They will keep
yes,
on coming.
yes. Many seniors have told.
Whatever times you do it, it will come.
Yes, if you go n number of times, you can resect n number of
It's
chips.
not there with enucleation.
Yes,
Yeah,
it's
yeah, yeah.
not there with that.
So that is the advantage of enucleation. And famous person has told a half done enucleation is better than a full done TRP.
Full length
So the results I mean to
Yes.
say is better than
If you
that.
can,
So we can
yes,
always
yes,
try
yes.
and learn new things and try. So thank you, Nitish, for joining with us, and it was a great presentation. Thank you.
Th- Thank you, Dr. Rakesh
Yeah.
and Dr. Chandramohan sir and Preeti Urology and Pure Urology for giving me this opportunity. Hope I could give some good insight or some different things to the viewers. We'll meet next time. Thank you.
Okay, sure. Bye bye.